It is now my pleasure to welcome Erin Seipel. Erin will be presenting on Nubeqa for non-metastatic castrate-resistant prostate cancer. Erin is the clinical pharmacist coordinator at Rx2Go Pharmacy. Erin, thank you for being here today. Take it away.
Thank you, Kevin, and thank you all for being here today. We'll just go ahead and dive right in. Nubeqa darolutamide is a next-generation androgen receptor inhibitor approved by the FDA in 2019 for the treatment of non-metastatic castrate-resistant prostate cancer in combination with ADT. Darolutamide received its Category 1 NCCN recommendation for patients with a prostate-specific androgen doubling time of less than or equal to 10 months based on the Phase 3 ARAMIS trial. Next slide, please. Non-metastatic castrate-resistant prostate cancer is a deadly disease. As we can see in the graph below, overall survival may be a long time, but time to metastasis, if untreated, is quite short. Next slide, please. As demonstrated in the graph below, a shorter PSA doubling time is associated with an increased risk for metastasis or death. Next slide, please. Darolutamide is an androgen receptor inhibitor. It competitively inhibits androgen binding at the AR nuclear and AR mediated translocation sites. In vitro, darolutamide functions as a PR antagonist and has been shown to decrease prostate cancer cell proliferation and tumor volume. Next slide, please. Darolutamide received its approval through the Phase 3 ARAMIS trial. It was a multi-center, double-blind, placebo-controlled clinical trial with a total of 1,509 patients with non-metastatic castrate-resistant prostate cancer with a PSA doubling time of less than or equal to 10 months. The trial was randomized in a 2-to-1 fashion where patients received either 600 milligrams of darolutamide twice a day or a matching placebo. All patients in trial received a concurrent ADT or had a previous bilateral orchiectomy. It should be noted that patients with a history of seizure were not excluded from this trial. Metastasis-free survival was the primary endpoint looked at in the ARAMIS trial. This was defined as a time from randomization to the time to first evidence of confined distant metastasis or death, or whichever had occurred first. The other secondary endpoints looked at in this trial included overall survival, time to pain progression, time to cytotoxic chemotherapy, and time to first systemic skeletal event. Next slide, please. Darolutamide more than doubled the median metastasis-free survival to 40.4 months versus 18.4 months with ADT alone. As we can see in the graph on the right-hand side of this screen, there is a clear separation between these two groups. It should also be noted that there was a 59% reduction in distant progression or death. Next slide, please. Our first graph shows median overall survival had not yet been reached, but upon final analysis, it showed a 31% reduction in risk, which was statistically significant. The darolutamide plus ADT arm delayed time to pain progression by 14.9 months when compared to the ADT arm alone. Next slide, please. Continuing on with our secondary endpoints, we can see here that the time to the first cytotoxic chemotherapy showed in the darolutamide arm a 42% risk reduction, and time to first symptomatic skeletal event, there was a 52% risk reduction. Next slide, please. Darolutamide has a different structure when compared to apalutamide and enzalutamide, which are considered our next generation androgen receptor inhibitors. Darolutamide demonstrates low blood-brain barrier penetration, which contributes to improved tolerability with this agent. Permanent discontinuation due to an adverse event occurred in 9% of men receiving darolutamide or placebo. Overall, 3.9% of men receiving darolutamide and 3.2% of patients receiving placebo died from adverse event. In the darolutamide group, it was noted as death, cardiac failure, cardiac arrest, general physical health deterioration, and pulmonary embolism. Next slide, please. Now for our meat and potatoes dosage and administration. Darolutamide is dosed at 600 milligrams twice a day. Patients are to take 2 300 milligram tablets. It's recommended that this medication be taken with food and swallowed whole. When it comes to our special populations, we must take into consideration patients that have severe renal impairment or patients with moderate hepatic impairment. Recommended in these special populations to reduce the dose of darolutamide to 300 milligrams twice a day. It should be noted with dose reductions and interruptions, these occurred in 6% and 13% of patients respectively due to adverse event. Most common reasons for dose reduction included fatigue, hypertension, and nausea, and most common reasons for dose interruption included hypertension, diarrhea, and pneumonia. Next slide, please. Most common adverse events noted in the trial included fatigue, pain in extremities, and rash. It should be noted that grade 3, grade 4 adverse events occurred in less than 1% of patients. Most common lab abnormalities noted in the darolutamide arm of the trial included decreased neutrophil count, as well as increased AST and increased bilirubin. Serious adverse events that occurred in the darolutamide plus ADT arm included urinary retention, pneumonia, and hematuria. Next slide, please. Darolutamide does have a warning of embryo-fetal toxicity. All males with female partners of reproductive potential should be counseled to use effective contraception during the use of darolutamide and for 1 week after its last dose. Next slide, please. In regards to drug interactions, darolutamide can inhibit BCRP transporters, such as rosuvastatin and glyburide, and increase their toxicities. If used together, frequent observation or monitoring for adverse reactions should occur, and possible reduction in dose of the BCRP substrate drug may be warranted. Next slide, please. Combined PGP and strong or moderate CYP3A4 inducers may decrease darolutamide activity. Concomitant use is recommended to be avoided. Combined PGP and strong CYP3A4 inhibitors may increase the risk of darolutamide adverse reactions. Next slide, please. And in conclusion, as we've covered today, darolutamide is dosed twice a day with food. It does have limited CNS penetration, resulting in better tolerance and quality of life for patients. Most common adverse events, though mostly low grade, include fatigue, pain in extremities, and rash. Darolutamide plus ADT showed a statistically significant improvement in metastasis-free survival with a median time of 40.4 months, and as well showed delay in time to pain progression. Next slide, please. References. Any questions?
Erin, thank you again for this wonderful presentation. It was very informative. And as Erin mentioned, we will now open it up for questions. If you have a question to ask Erin, please enter that question in the Q&A box and it will be answered in the order in which it was asked. So we do have a few questions coming through. Erin, the first question we have, the data suggests that the side effect profile is pretty minimal. Has this been your experience as well with this drug?
In my personal experience in practice, absolutely. I tend to get way more calls from patients when it comes to Xtandi or Erleada. I get very few calls when it comes to our Nubeqa patients. They do tend to do very well when I follow up with checkup. They don't really have much to tell me, but always appreciate a check-in.
That's great. Our next question, Have you had a patient that stayed on a BCRP substrate drug along with Nubeca? And if so, how was that managed?
That I can recall, no, I have not yet had any personal experience with that.
In terms of things that should be eaten or shouldn't be eaten, are there any dietary restrictions with this drug? And in addition to that, how about lab monitoring? Is there
So
a
there,
specific time where patients should return to get their labs done?
um, in the PI, there is no noted food restrictions with the medication. I know the one we always are concerned about is grapefruit juice. I did double check that actually before because I just think everyone should avoid grapefruit and grapefruit juice. But there was no interaction that was noted when I screened it through LexiComp as well. In terms of lab monitoring, they don't give any specific guidance when it comes to the actual monitoring with the labs in the PI.
Thank you so much, Aaron. And the final question we have today, what do you feel are the main takeaways for members to bring back to their practices on this therapy?
Just overall tolerance, I would say, is the big thing. I know in our practice, this does tend to be a little bit of an underutilized medication. So just bringing it to the forefront, how this medication is very well tolerated, and patients can definitely benefit from the use of Nubeca.
Awesome. That's great, Aaron. Thank you so much for your presentation today. We greatly appreciate it. So thank you again.
Thank you guys for having me. I appreciate all the questions.
Our second presentation of the day will be presented by Astrid Slaughter from Texas Oncology Round Rock. Astrid will be presenting on Tukysa for advanced metastatic HER2 positive breast cancer. Astrid, thank you so much for being with us today. The floor is yours.
Thank you very much. It's my pleasure to actually present something on Tukysa today. If I could have the next slide. Thank you so much. Tukysa is actually quite a big deal if we are looking at metastatic breast cancer. It has recently been approved, and actually the approval was fast-tracked, so it got approved 4 months ahead of the schedule. The approval actually was in collaboration with other countries like Switzerland. So that just shows that there's a need for a drug like Tukysa to help out patients who have progressed on multiple regimens already, who are dealing with metastatic breast cancer. Actually, the FDA gave Tukysa a priority review and breakthrough therapy designation. And as of right now, it is a category 1 NCCN recommendation. Tukysa in combination with Herceptin and Xeloda. It is currently the only category 1 recommended regimen if you are looking at a systemic treatment for metastatic breast cancer. If I could have the next slide, please. To show you a little bit the mechanism of action. If you're thinking about breast cancer, it sometimes is tempting to think that they are all targeting a domain similar to what Perjeta and Herceptin do. Tucatinib is actually a tyrosine kinase inhibitor, which is selective for HER2. It basically leaves growth factor receptors alone, which adds to a better side effect profile. And basically in our study that I will present next, it actually works in combination with the HER2 inhibiting capacity of trastuzumab. If I could have the next slide, please. Tukysa was investigated in the HER2CLIMB clinical trial. We are looking here at an international double-blind randomized study. And participants either received a combination of Tukysa plus Herceptin plus Xeloda versus placebo plus Herceptin and Xeloda. In order to be eligible for the study, patients had to have HER2 positive advanced breast cancer, breast carcinoma, and they had to be previously treated with Herceptin, Perjeta, and Kadcyla. Performance status for those patients that enrolled was quite good. We are looking at a performance status of 0 to 1. And here is the interesting part. If those patients had already metastasis to the brain, they were still eligible to enroll in the study. If you're interested, at the bottom of the slide, it gives you the publication at the New England Journal of Medicine. If I could have the next slide, please. Here you see the study design, the participant number of 612 patients who got randomized to either the Tukysa arm or the control arm, which is once again placebo plus Herceptin and Xeloda. We were looking at the primary endpoint. Progression-free survival was used as a primary point, and also overall survival and progression-free survival in patients with brain metastasis were taken into account. If I could have the next slide, please. The study results were basically published 1 year after starting the study, and then the second year after starting the study. And it shows that basically the Tukysa combination has an advantage. If you're looking at the progression-free survival, 7.8 months in the first year compared to 5.6 months for the placebo. At the second year, we are looking at an overall or median duration of overall survival for 21.9 months for the Tukysa combination versus 17.4 months for the placebo. There's also a definite advantage for people with brain metastasis. If we are looking at the progression-free survival, Tukysa gives an advantage, 7.6 months versus 5.4 months for the placebo. And also, if you look at the overall percentage of patients that had a progression-free survival with Tukysa, that's also something that's quite important, since right now we do have kind of a good grip on metastasis alone, but as soon as we are talking about cancer that has spread to the brain, we are still kind of in the infancy. You could do radiation, which comes with side effects, of course. So definitely Tukysa has proven its worth here for this patient population. If I could have the next slide, please. This slide shows the treatment regimen. And I took this graphic from the Tukysa website. Once you have patients who are actually receiving this combination treatment, it is important that they understand on how to take medication. What we see at our practice is sometimes if you add another medication onto somebody's schedule, you have to consistently reiterate how they take it. And I think this graphic would be a good handout to give your patients, because it shows that the Tukysa they take continuously. It's 300 milligrams twice daily, approximately 12 hours apart. Every 3 weeks, they come in for their infusion. And the capecitabine is taken twice daily, but only for 2 weeks. Then there's 1 week of a break, then it starts again. What I like about this treatment is that you can combine the Tukysa and the capecitabine, because if that would be not combinable at the same time, patients might forget. But here they can basically take both the Tukysa and the capecitabine within 30 minutes of their morning and their evening meal. If I could have the next slide, please. Here's a little bit concerning the prescribing information for Tukysa. It is obviously approved in combination and Xeloda. patients have to have at least one prior HER2-based regimen, and they have to suffer from metastatic HER2-positive breast cancer. The dose that you start out with for the Tukysa is 300 milligrams twice daily, once again with or without food. If the patient suffers from hepatic impairment, dose gets reduced to 200 milligrams twice daily. That's why Tukysa comes in two different formulation strengths, 50 and 150 milligrams. If I could have the next slide, please. Unfortunately, there are side effects to this regimen. What we basically appreciate is when our patients have a little bit of time. So when we first start the medication, we like to give them a good overview over what they can expect from this treatment regimen. Most common side effects for the Tukysa are diarrhea. We always tell our patients to reach out to us early so that they are not in a bind and would have to either delay treatment or possibly forego treatment with Tukysa. Other common side effects can be rash, pain, swelling, blisters to the palms of your hands or feet. You already realize that that's also a side effect of the capecitabine. So it's definitely important that patients are counseled. It is also worth mentioning that while on Tukysa, they have to come in and do frequent lab work. We are looking especially at the liver function tests. Mouse source can also be possible. And once again, it's good for them to reach out to our patients to reach out to us early on. If I could have the next slide, please. What do you do when you have a patient who basically comes to your window and tells you that they actually experience diarrhea? Your provider might also ask, what can I do? If they see a patient in the office visit and they just presented with grade 3 diarrhea, then the prescribing information for Tukysa actually gives suggestion on what to do. Basically, recommendation is for either diarrhea or hepatic impairment to hold Tukysa and then resume it based on how severe the grade is, either resume at the same dose level or go one level lower, so that patient still has the benefit of taking Tukysa. If you look at the liver values, unfortunately, if your enzymes are severely high, the recommendation is to permanently discontinue Tukysa. Could have the next slide, please. As far as dose reductions go, the first dose reduction would be dose reduced from 300 milligrams twice daily to 250 milligrams twice daily. Then the second one is 200 milligrams twice daily. The third one is 150 milligrams twice daily. If the patient unfortunately cannot tolerate Tukysa at the below the 150 milligram dose, then the recommendation is to permanently discontinue it. If I could have the next slide, please. There is a lot of resources support for your patients available. If you look at the Tukysa website, it gives you the option to provide your patient with a treatment tracker, basically where they can take keep track of their dosing, take notes about how they feel, side effects. We also like to encourage our patients to write down any side effects that are bothering them. that are new to them since they started to Kaiser, to write them down in a journal and bring that journal with them to the next office visit so that they know what they want to discuss with their provider. If I could have the next slide, please. This is the treatment tracker, also taken from the TUKAISA website. And basically, if you look to the right side, it will basically, you see that it gives you the option already to take notes on how patients feel. They can say, hey, I missed the dose. That helps them also to be accountable for the regimen, because the best treatment is useless if somebody is not necessarily able or capable of taking their medication on a regular basis. If I could have the next slide, please. Encoda also offers a resource tool for TUKAISA. It is basically a one-page resource that can be easily given out to your nurse, your pharmacy technicians, your mid-level providers. They can basically go on Encoda and print it out when they do a treatment regimen overview with their patient. It mentions all the important side effects. It also mentions that they have to come in for blood work regularly. It also tells them what the other two medications are, since TUKAISA is given as a 3-drug regimen. If I could have the next slide, please. As far as clinical perks go, definitely once again, liver function needs to be checked before, and it's recommended to have the patient repeat this every 3 weeks. Resources for patients can be found on Encoda, can be found on the TUKAISA website, can also be found on all chemo education sheets. Website is at the bottom of this page, and the patients basically have to keep in mind to take TUKAISA every single day. Next slide, please. Thank you very much. I really appreciate having the opportunity to talk about TUKAISA, and I am ready for your questions.
Astrid, thank you so much for your presentation today and for taking the time out of your day to be here. As a reminder, if you would like to ask Astrid a question, please type out your question in the Q&A box and we will answer them in that particular order. So the first question we have, Astrid, is there patient assistance available for TUKAISA?
Yes, there is. TUKAISA is a newer treatment, and these newer treatments tend to come with a certain cost. There's definitely patient assistance available. I would like to give a shout out to Texas Oncology. We actually have our own patient assistance team, people that basically only focus on finding resources and assistance for people who start on treatment. And yes, TUKAISA also offers patient assistance for those in need.
Thank you very much. Our next question, what happens if a dose of TUKAISA is missed? Should a patient make up for the dose, or should they skip the dose?
This is also something that definitely should be mentioned during a chemo teach, or when you have the patient at your pharmacy window. The current recommendation is to skip the dose and not try to make up for it.
Thank you for that insight. How have you managed the complexity of this regimen as far as patient compliance and understanding goes?
We actually like to check up with our patients. You know, they're coming in every 3 weeks for their Herceptin infusion. So we offer all medications to our patients, and we also obviously do infusions. We also always like to come out and ask them how they feel. If we don't see them at the window when they pick up some other medication, we definitely like to take the opportunity to always check up on them and just ask them random questions, how they feel, if they take the medication regularly. It's definitely a key point for everybody who works in oncology, especially if you give out medication that patients take home. you cannot control what they do with it. So definitely giving out frequent reminders, follow-up calls if you don't see them coming in. It's definitely something that we like to do.
Perfect. Thank you. We do have a few more questions here. How do you decide which drug to dose reduce first in a regimen like this? Thinking about abdominal pain and things along those lines. Both could be from capecitabine or Tukysa. So how do you decide which drug to dose reduce there?
We work definitely with our clinical providers on that one. We try to look at the most recent lab work, if the liver enzymes are involved. As far as diarrhea goes, since that side effect is more prominent on the Tukysa medication, we would do a dose reduction on that one first. If we think that hand-foot syndrome is very prominent, then we would try to dose reduce the capecitabine first.
Thank you very much. And the final question we have today, Astrid, are there medications that interact with Tukysa?
Yes, unfortunately there are. And basically, it's not a surprise. These are all CYP enzyme either inhibitors or inducers. We definitely, if a patient gets a new oral medication with us, we definitely like to look in their profile what other medications they take. For example, if they are on something like clopidogrel, a CYP2C8 inhibitor, we try to work with the provider to either find an alternative or watch the therapy closely, since if you're talking about CYP inhibitors, the Tukysa toxicity might be increased. And if we talk about drugs like phenytoin, phenobarbital, those induce CYP enzymes and could lead actually to less Tukysa medication that's available in the bloodstream for the patient. Generally, if we look at those combinations, the general recommendation is to avoid them and find alternative therapies, which might not necessarily always be possible.
Well, Astrid, thank you so much. Those are all the questions that were submitted today. So again, thank you for answering all of them, but also thank you for your great presentation.
But thank you very much for having me.
At this time, I would like to thank Aaron and Astrid once again for their presentations, and I would also like to thank Bayer and CGen for sponsoring today's webinar. From all of us at Encoda, thank you to everyone who was able to join us today, and we hope to see you all on the next webinar. Thank you.